All right, we can get started. Hello, everyone. Welcome back to My Medical Message. I know we haven't been doing these shadowing sessions for about a month, but we're back at it now, and we have a lot of speakers lined up for you for the next few months. All right, we can get started. All right, my bad. All right, so today we have Dr. Horawski. She's a family medicine resident right now, and she is here to talk to us all and answer your questions about family medicine. So welcome to My Medical Message.
Hi, everyone. I'm Dr. Jennifer Horawski. I'm a family medicine resident in Myrtle Beach, South Carolina. I just started my second year of residency. I'm originally from Toronto, Canada. I went to the University of Waterloo and I studied kinesiology. I then went to medical school at Ross University School of Medicine when it was in Dominica. And now I've matched here in Myrtle Beach, South Carolina. Basically, I ended up choosing family medicine for what I wanted to do for the rest of my life because I really liked the range in patients and different things I could see in different ways that I'd be able to tailor my practice for however I want it to be in, the different stages of my coming life. So that's really why I chose family medicine, along with the longevity of the relationships that I form with my patients, who basically turn more so into like friends. So that's kind of why I chose family medicine. Kind of a background of family. So family medicine basically covers all sorts of patients at all different stages of their life. So we're able to see pediatrics, so kids, we can see babies, teenagers, adults, and and then the more like geriatric and elderly population as well. We colloquially like to refer to ourselves as people who take care of patients from birth to gravestone. Because of that, we kind of see a whole lot of different things throughout our day. And we can practice in various different clinical settings. Most family doctors practice in an outpatient setting. So like in a clinic, as many people see their family physicians out in just the clinic. There's some that have what you can call like admitting privileges. So if they're associated with a hospital, they can have the privilege to be the doctor that rounds on that patient in the hospital if they're one of their clinic patients. There's family physicians that work as like a hospitalist, so they round on patients in the hospital. So any patients that are admitted on the floor, whether it's for like a stroke or, a heart exacerbation or an asthma exacerbation or anything like that, they can also do that as well. There's also various different fellowships that you can do within family medicine. I myself am interested in a sports medicine fellowship. So that's an additional year on my residency training for fellowship. So 3 years of family medicine residency and then 1 year of sports medicine fellowship. That would be my plan. But there's a lot of other various different specialties. There's also like an OBGYN fellowship. So for anyone who wants additional training for OBGYN, so like birthing babies and women's health and stuff like that. There's more like behavioral aspects of it. There's an emergency medicine fellowship for people who decide they want to work in the emergency department. There's really like the opportunities and options are basically endless with family medicine. So, I mean, if there's something that you are interested in family medicine, 9 times out of 10, you are able to kind of like specialize your clinic. If you want to be in an outpatient setting, you can kind of specialize it and tailor it to a specific aspect of family. So that is kind of like the big overview of family medicine. What I normally see or do in a day, it kind of varies depending on the rotation I'm on. So in family medicine and in residency, for us, it's by month. So every month we're in a different rotation. So for example, this month I'm on a gynecology rotation. So I'm working in a gynecology clinic. So it's more focused on women's health, preventative screening, that kind of stuff. My month I just came off of was an inpatient family medicine month. So I was rounding on the patients in our hospital. So at that point, I'm seeing more of the patients that are admitted to the hospital. So whether they have like a congestive heart failure exacerbation or a COPD exacerbation or, that kind of stuff. So more things that would be more acutely managed in a hospital. We also rotate through like outpatient pediatrics. What else do I do? Urgent care, emergency medicine. We kind of cover a little bit of everything. So, yeah, that's kind of like, I guess, a broad overview of what I have been doing as a resident so far. I know there's like a slew of questions coming in, and I hopefully answered some of them as I was babbling, but I'm going to start reading through them. Okay, so pros and cons of family medicine. Pro is definitely you can tailor it to your family lifestyle at whatever point in your life that you're on right now. So like a lot of my faculty members and stuff like that, they were interested in doing traditional family medicine. So they were the ones who they would birth their patients' babies and stuff like that. Obviously, that's a little bit more time consuming and you're on call all of the time. But they did that for several years. They worked in a more rural environment. When they decided that they'd had enough of that, then they moved more into the city and kind of changed their practice at that time. So that's definitely a pro, is you can kind of change what you want to do as your interests change and as your life circumstances change. A con, I don't know whether I know a con about family medicine, but I'm also biased. I mean, I guess a con is there's so many options that, it can be overwhelming at times because, you might find a whole bunch of different things interesting and you don't know what you want to focus on. I can definitely see that as a con. But also another pro is everybody needs a family medicine doctor. So, we're in high demand. Let's see. What's the major differences between working with children and adults? I would say really the major difference is just dosing, medications really. Medications are just often given very differently in kids versus adults. But I mean treatments and everything is really pretty similar. I mean, when I'm working on an inpatient pediatrics floor, versus an adult medicine floor. I mean, the medicine is the same. The diseases might be a little bit different, but the medicine is the same. Because I mean, whether I have an adult that's in a lot of pain or having trouble breathing versus a kid who's in a lot of pain and having trouble breathing, I'm obviously going to be treating them the same way, but medicines and dosing those medicines and everything like that, it's obviously tailored a little bit different. In kids, for example, a lot of the dosing is based on their weight, whereas adults, it's not. So for kids, for example, you might dose a medication like 5 milligrams per kilogram or something of that nature. Whereas an adult, you don't have to do stuff like that. So that's, I guess, really the major difference between kids and adults, but both are equally rewarding and a lot of fun. Let's see, what new advancements and new technologies have been developed in the past few years that have improved how you do your job? I would say having like electronic charts and everything like that has been super beneficial in the sense that I have everything at my fingertips and I don't have to go searching through a file for it. But it's also hindering in the sense that when I'm going into a patient room to talk to a patient, I'm also trying to type everything down and make sure billing codes are in there and assessments are in there. And, you know, I find it kind of pulls away from that sometimes too. So it's like a catch-22 because I mean, it's great because everything's at my fingertips. I can get like prescription refill requests to my phone for my patients, which just make it a little bit easier. But at the same time, it makes it more challenging. And I think it makes it a little bit harder to take a step back from work because it is so at your fingertips. It's harder to leave work at work when you come home, if that makes any sense. But it has definitely been helpful with like documentation and everything kind of being in the same place. And we're able to see records from other clinics and stuff like that. So that has definitely helped. Yeah. How is the practical training in family medicine residency different from other medical residencies? I'm not 100% sure what you mean by this question, but I'm going to try answering it based on what I think you mean. So like family medicine is a mixture of like clinic, so outpatient stuff and inpatient as well. So we get a little bit of a mixture of both. I'd probably say like a 50-50 kind of split. Whereas other residencies might have a little bit more of like a 70-30 or a 60-40 split between maybe like hospital medicine versus outpatient medicine. But family medicine is more of like a 50-50 split between rotations that you do in the hospital versus rotations that you do in a outside clinic. Let's see, can family physicians have any active involvement in an operating room, hospital, or are they mostly working in clinics? So operating room, not 100% sure, but definitely working in clinics. They can do their own procedures. I mean, yeah, there's really sky's the limit on, you know, what you want to get involved in the hospital as a family medicine doctor. There's also internal medicine, which is like family medicine, but without kids and is more inpatient based. So in the hospital. Yeah, I mean, you can, as a family medicine doc, you can kind of pick and decide whether or not you want to be in the hospital or outside of the hospital, or maybe a little bit of both. It's up to you. Let's see. How often do you come across something you're unfamiliar with? All of the time. And how do you approach these situations? I think something that I learned very early on in medicine and in my medical training, which I've told to every student that I've mentored, is to get comfortable with being uncomfortable. That's kind of what I've been continuously telling myself throughout medical school, because as soon as you start feeling comfortable with something, something changes, or you're moving into a new rotation, or you're in a new hospital and things change again. So I think through medical school, I developed the ability to be comfortable with being uncomfortable. And I think that that's a good skill to have throughout medical school. And then that also translates into residency as well. Because as soon as you start thinking you know everything or you're comfortable with everything, that's when something's going to pop up that you've never seen before. And you're going to be like, oh my goodness, what's going on right now? So throughout my training, as you get more exposure to it, you get more comfortable with being able to kind of think on your feet a little bit quicker. And as you've seen, like, you might not be exposed to this specific case exactly, but you've been exposed to something that was kind of similar, and then something else that was kind of similar in another way. So then you kind of, maybe like mix the two of those together a little bit and try that out. But I mean, as a resident, we also have like a lot of guidance and support from senior residents as well as attendings that can answer, a lot of our questions or help us in those hazy situations where you're like, well, I don't really know what's going on right now or how I want to manage this. There's always seniors and attending physicians who can help guide you through those situations. But I always try to like keep a level head and just take a step back and try and logically think my way through it and not let it trip me up. That's kind of how I've dealt with those situations. And so far it's been pretty successful, but that's what I've been doing. And then what are the most common cases you see? Most common cases, a lot of like diabetes management. So, diagnosing somebody with diabetes, or somebody has diabetes already. So managing like the medications they're on, whether they're on like insulin or just like oral tablets, or they're managing their diabetes with their diet. So that's a pretty big one. Another one is probably like hypertension, so high blood pressure, hyperlipidemia, so like high lipids, or like elevated cholesterol, asthma. I mean, we kind of see literally a little bit of everything. Yeah, I mean, but a lot of diabetes and like cardiac, so like heart stuff, and then like stomach stuff, and we just get it all. Everything's common in my head right now. Let's see. Do I plan on doing any fellowships after I finish residency? Yes, I want to do a sports medicine fellowship. Because I did my undergrad in kinesiology, I've always been interested in sports medicine and doing that in like a primary care setting. So that's what I plan on doing afterwards. So that's my plan. What is the main difference between Medpedes, internal medicine, and family medicine? So for internal medicine versus family medicine, what I was told when I was applying was do a residency in internal medicine if there's a specific organ system that you're interested in. So whether it be you really love like endocrinology, like you love diabetes, the thyroid, the adrenals, all that stuff. If you're really jazzed up about that, do endocrinology or do internal medicine, and then you can do a fellowship in endocrinology. Or if you really love the heart or the GI system or, you know, something of that nature. Versus if there's a specific patient population that you like, then go into family medicine. That's what I was told when I was applying to residency. And I think that was pretty good advice, just because internal medicine has a lot more of those specialized fellowships within specific organ systems versus family medicine. I feel like the fellowships are more focused on specific patient populations, like women's health or like adolescent, so teenagers, sports, so like more athletes, behavioral health. I think there's even like an LGBTQ fellowship that's like in the works. For definitely internal medicine versus family medicine, specific patient population versus organ system. For Medpedes, I think that is more, so if you go into a Medpedes residency, you become board certified in both pediatrics as well as internal medicine. So if that is something that you're interested in and becoming board certified in 2 different specialties, then I would pursue that track. The med part of it would definitely be more inpatient heavy. And then you'd also get the inpatient side of pediatrics as well. And I don't know off the top of my head how many Medpedes programs there are, but I know that there's not as many as obviously internal medicine and family medicine residencies. How competitive is this field of medicine? I wouldn't say super competitive, because there's a lot of family medicine programs and residencies and a lot of spots. So I wouldn't say super competitive, but you know, it's obviously all like very important for you to have, you know, strong letters of recommendation, obviously a desire to want to be a family medicine doctor, and to apply like smartly, you know, not being too, I guess like specific and picky about, you know, oh, I only want to be in this one state or this one spot. That obviously makes things a little bit more competitive versus kind of applying a little bit more broadly. And what does an average day in the field look like? So it kind of depends on whether you're doing inpatient or outpatient. Generally inpatient, so in the hospital, I'd be getting into the hospital around 6 o'clock in the morning. I would check on all of my patients' labs that I got done overnight. And then go see them in the morning, round on them with my attending, write my notes. Those days tend to be a little bit longer. And I was normally there until like 5. And then on call days, I was there until 7 o'clock at night. It's a little bit different when you're attending, but just as a resident. Clinic schedule's obviously a little bit more regimented, 8 to 5. and normally no weekends. But yeah, that's kind of what my schedule is like. How do you deal with young patients that aren't cooperating? I mean, it's hard to deal with like a toddler, for example. One of the hardest things is getting a toddler or something like that, trying to look in their ears. None of them like it. They all scream bloody murder when you try and look in their ears. So I've played with them to get them to trust me a little bit more. And then I find that works a little bit, and then they'll let me look in their ears, because there's nothing more difficult than trying to look in a toddler's ears as they're screaming in your face and moving around and everything like that. So I try and like bond with the child so that we can form like a good working relationship. How is the work-life balance in this field? It depends on the rotation. Inpatient, for example, more work, less life. For that, I would be working 6 days a week with 1 day off. And then on outpatient months, I have a regular work week, Monday to Friday, 8 to 5 or 9 to 5, whenever clinic's open. And so, yeah, it kind of depends on the month that I'm rotating on. Once I'm done, residency is known to be harder though and more time consuming. But when you're looking at a field, you want to look at the attending's work-life balance, because that's ultimately where you're going to be sitting for most of your life, because once you're done residency, that's what your schedule is going to look more like. So family medicine doctors' work-life balance, I think, is pretty good after residency. They're able to, especially on the outpatient kind of schedule, as they see fit. If you're outpatient, you get weekends off, holidays. Inpatient, you're not working, every single day for a month straight or anything like that. It all depends on like the way hospitalists are scheduled at the specific hospital. So where I'm at currently, the way they schedule it is I think you have to have like a minimum of 14 days coverage at the hospital in a month, I think. And normally they'll do like 7 on, 7 off. So that's how some inpatients services work. So it's not the same as, inpatient when I'm a resident where you're working there for 4 weeks straight. It's entirely different as an attending. Let's see, what's next? What do you think the biggest challenge in healthcare? What is the biggest challenge in healthcare right now? That's a good one. The biggest challenge in healthcare right now. I mean, other than COVID, because that's kind of been a biggie. But I think the biggest challenge is just finding a physician that you work well with and you trust. I think that's the biggest challenge, because I've noticed with a lot of my patients, a lot of them will say, oh, I've been to a few physicians, I don't feel like I've like built a really good relationship with them, and then I don't want to come back. And I feel like that's the biggest challenge right now, is just building solid relationships with our patients. Yeah, I think that would be the biggest challenge. What are basic resident benefits? It depends on the Like every residency in every hospital is a little bit different. But you're obviously going to get your salary, dental, vision, healthcare, um, and then, like just, stuff like that. I mean, it's nothing extravagant or special or anything like that. At my hospital, we could pick like different tiers of healthcare coverage that we wanted, and like dental coverage and vision and stuff like that. But yeah, just, regular medical benefits. Where I am, we can get like a 401k and stuff like that. So some programs offer that as well. I'm not sure about everyone, but mine did. What drove me to choose family medicine? I chose family medicine because I have had the same family medicine doctor since I was minus 9 months old. She was my mom's family medicine doctor, and then she was mine, and she was just always so great. She provided a lot of support for me going through medical school. She was always like there for me as someone, I felt comfortable talking to if I had any like questions or concerns. I never felt like she judged me or thought any different of me if I had like different random questions for her. And she always just took the time to sit down and like make sure I understood what she was talking about. So that is really what drove me to choose family medicine, was because I wanted to be able to do that for my patients in the future, because I felt super fortunate that I was able to have that experience as a kid growing up. And I still I have phone calls with my family physician still, and now we chat, I guess, more so as colleagues, which is nice. But yeah, I'm really fortunate and very lucky to have a relationship like that. What physicians do you typically work with? So as family medicine, we kind of rotate everywhere. So I work obviously with family medicine doctors. I work with internal medicine doctors, cardiologists, gastroenterologists, orthopedic surgeons, rheumatologists, pediatric doctors, ear, nose, and throat doctors, dermatologists, emergency medicine doctors, surgical, like general surgery doctors, literally everybody. Family medicine works with everybody. What makes family medicine stand out? Do you work with other specialties? Yes, I work with other specialties, as I just answered. But what makes family medicine stand out is definitely, the opportunity to kind of make family medicine what you want. I think that's a really special part of family medicine that you can't find in any other specialty. Is it common for residents to pursue fellowships? I don't know how common it. I mean, yeah, I think it's pretty common for residents to pursue fellowships if they want to. But if they don't want to, they don't have to. I feel like there's really there's some fellowships that it's not mandatory to, but I mean, if you got a lot of exposure to it in residency, and that's something you just want to focus your practice on when you become an attending, then you don't need a fellowship for it. Like an OB fellowship, for example, it's not entirely required. There's also a hospitalist fellowship for people who want to work more so in the hospital. But that's not required too. It's just for someone if they feel like they just want that additional year of training for it. Who do you typically get letters of recommendations from? Normally, when you're applying for fellowship, you have to have one letter from your program director. So that's an automatic letter. Other letters, it could be other faculty that you work with frequently, whether it's in the hospital or in the clinic or on one of your rotations. And if you wanted to match into a fellowship in a specific sports medicine, for example, you know, getting a letter from a sports medicine doctor would be important. Or if you wanted to do an emergency medicine fellowship afterwards, you know, getting a letter from an emergency medicine doctor would obviously look good. So that there's no cookie cutter way of, you know, what letters you have to ask for, but one has to be from a program director. Can children have both a pediatrician and family medicine doctor, or is it typically one or the other? Normally, I mean, some people will either just have a family medicine doctor and that's who they have. But some people will have a pediatrician up until they're 18 and then transition to a family medicine doctor. But either way is fine. There's no wrong way to do it. Do you usually see one patient at a time, or are there situations where you've seen an entire family at once? Yes, I have, I call them like my group deal patients, where there might be, a lot of the times I see, well, it'll be like, you know, 2 or 3 kids will come in at the same time, or a husband and a wife will come in at the same time. And, you know, you see both of them. But I normally just, you know, like, okay, we're going to talk about you now, and then get my interview and questions and everything done for this patient, then move on to the next one. I can't do both at the same time. My brain does not work that way. How has COVID impacted your work and how you treat your patients? There's been a lot more like televisits now. So, you know, patients being able to schedule appointments, and I like have a Zoom conversation. It's not Zoom exactly, but I have a conversation with them over the computer. And I think that's something that's probably going to stick, just because it's super convenient for some of our patients. And I find that, you know, for some of my patients, when they come in and they just need a refill of their medication or something like that, I mean, it's easy to just talk to them, see them on the screen, ask them how they're doing, if they have any questions, and then I can just send them a refill, as opposed to them having to come in, especially if they have difficulties getting around, or with COVID and everything, that made it harder for them. So that's how it's really affected our patient care, I guess. Do you still see a family physician for yourself, or do you no longer need one as a physician yourself? I mean, doctors are the worst patients. I did see my family doctor before I came down here. And I have seen a family doctor since I've been here. Do I need to go back and see them again? Yes. Have I had time to? No, but I know I need to. Is there a certain age demographic you tend to cater to? I find I get a lot of like teenage and young adult females, but I think that that's because I am a young female, and girls tend to be more comfortable with seeing a younger female as their doctor. But I mean, I'll see everybody. I'm happy to treat everybody, male, female, old, young, whomever. I'm happy to see whoever. Do you ever have to do late night shifts in family medicine for any reason? Yes. So there's night shifts when you're covering the patient lists overnight, or like long call when you're on inpatient services and stuff like that. So yeah, there's unfortunately later night shifts. How was my experience going to a Caribbean med school? Would you recommend it? And were you considering other specialties besides family medicine? Caribbean med school, I mean, it was hard. I mean, the Caribbean med schools are known notoriously for bringing in a lot of students, and then there's a high attrition rate. But as with any medical school, you know, you get what you put into it. And if you're willing to put in the hard work and dedicate yourself and study, there's no reason why you can't get through medical school. It's just being dedicated and studying and wanting to be a doctor more than studying sucks at the moment, because it does get better. Do you do a lot of directing patients to other doctors in different professions depending on the patient's needs? Yeah, I mean, if there's, I feel like I can manage a lot as a family medicine doctor because we are trained for it. But if something is starting to get more complicated where the patient might need an escalated level of treatment or specific medications or treatment modalities, then I refer obviously to the specific specialists. But for example, for like regular run-of-the-mill high blood pressure or diabetes, that's something that I can personally manage myself. I don't need to refer out for that. So yeah. And then some patients, they want the referral out to see a cardiologist or an endocrinologist or something because they saw one previously and that's what they want. So, I mean, if they prefer that, then I'm happy with that too. And I can just manage their other medical conditions. Has the patient physician confidentiality rule ever gotten in the way of proper care or treatment? I mean, there's a lot of like obviously ethics behind it. And I've been slowly learning it more and more as I've gone through practicing more about, say, for example, who you can discuss patient information with. And if a patient becomes incapacitated, who can make those medical decisions for them? And I feel like as a family medicine physician, it's my job to be able to make sure that my patients are set up well enough that if the unfortunate event was to arise where they're not able to speak for themselves, we have all of those things lined up so that there's not a question of, are you, for example, are you a full code or are you a do not resuscitate? Like stuff like that. So that's something that I feel like as a family physician is very important for us to deal with. Do you think telemedicine would be effective for most specialties or only just a few? I mean, there's some things that obviously you need to be in the clinic for, you know, if you need to do an injection or if you have a very specific injury. But I mean, if it's somebody who wants to talk to me about refilling their medication or, you know, I started them on a new blood pressure medicine and I'm just doing a blood pressure recheck just to make sure that their blood pressure is coming down. It's not too high, it's not too low. Then yeah, telemedicine's absolutely okay for that. But if, you know, you have an injury or there's something that, you know, I'm going to need to do a physical exam for and see you, then I can't do that over telemedicine. I can only gauge how you're looking at me and talking to me and speaking with me. I can't do anything more physical than that. Have you ever thought about starting your own practice in the future? Yes, I've thought about it. I think I'm going to get a few years of practice under my belt first, and then probably start my own practice. But something I'm tinkering with. Stay tuned. I don't have the answer for you yet. And what recommendations do you have for students going into college or medical school? Going into college, I would say study what you're passionate about. Focus on what you're passionate about because that's an important time to, you know, be able to focus on that stuff. And I've told this to multiple mentees that I've had where when you apply to medical school, it's not just like, oh my gosh, this person has 55 publications in a biological journal or something like that. You know, you can, like, people who have life experiences of, you know, they were like, they had a minor in, I don't know, theology or fine arts or something like that. Like, that is something that, like, when you're looking at applications, you're like, oh, okay, that's kind of cool. I mean, as in my opinion, as long as you hit those prerequisites of, you know, certain amount of biology, chemistry, physics, gen chem, orgo chem, and the labs and everything associated with it, the rest of the stuff, you can do whatever you want with it. I mean, I was the only person in my class who did kinesiology, and I feel like kinesiology has helped me out more than I ever could imagine. It was probably the most useful degree amongst all of my friends, just because I use it every day. But I have friends who, like, their undergrad degree was like an English major, with another, like, a fine arts minor, and, like, they still got into medical school. They're still great doctors. But I mean, whatever you're passionate about, do that, and it's going to shine through on your application. Because if you're not passionate about something, it's just going to be work, and you're not going to enjoy it. For medical school, it's just trudging through it. What helped me get through medical school was, I'm not the first person who's gone through this, and I'm not going to be the last person to go through it. So that's really what got me through medical school, because leading into the next question, what were the early days like in medical school? It was a lot of books and libraries and not sleeping and coffee, and a lot of stress, because it's very different from college. But I just kept telling myself, I'm not the first person, and I'm not going to be the last. And, you know, whether or not my classmates are admitting to the fact that this sucks and they don't feel like they know anything either, everybody's in the same boat, and we're all trudging through basic sciences together. Because, yeah, the first 2 years of medical school was so much studying. And then third year was, you know, a lot of hospital work and stuff like that too. So it's very tiring, but the most rewarding thing, and I would do it again in a heartbeat. Gap years, I mean, I think they're great. I didn't take one, but a lot of my friends have, whether it was to do research, travel. I have a friend that was, like, in a rock band for a few years before she decided she wanted to go to medical school even, and, like, that's cool. She had, like, great life stories. So I mean, if you feel like you need to take a gap year, then, like, you do it. There's no right or wrong way to get into medical school. If you want to take a gap year and travel and, you know, live your life a little bit, then I don't think anybody should tell you no, or that that's a bad idea. Are you required to do research? I don't know whether every program is the same and how different it is across different specialties. But for family medicine, we're required, at my program at least, to do a quality improvement project. So a way to, like, improve our practice. And then we're expected to do, whether it's like a poster study or, you know, like a case abstract or something like that to present. And I'm pretty sure numbers, I don't know the exact numbers, but I'm pretty sure every residency requires at least a quality improvement project and some type of presentation of a case. What other specialties would you say are closest to family medicine? I mean, technically peds is close, it's just kids. Internal medicine is close, it's just not kids. OBGYN is close, it's just the moms though, and we're not in the OR. But I would say like probably peds and internal medicine. It's just one has kids and one does not have kids. But yeah, I would say those two are the closest to family medicine. But I hope that helped. Oh, what's this? Do you ever wish you went into a different residency? Mm-mm. I know this is where I'm supposed to be. I like family medicine. I like it a lot. There's a lot of variety, which helps keep me occupied and not bored. So I hope those answers help you guys. Because I've been in your shoes before, and I know how daunting and scary thinking about going to medical school is, writing the MCAT, applying to medical school, being in medical school, applying to residency. I know how scary all of that is and how stressful all of that is, but it is entirely doable. Just, stay true to yourself, and your values of, the kind of person you are and the kind of doctor that you want to be. And I think that's the most important part. And, always remember that you're not the first person to go through it. You're definitely not going to be the last person to go through it. And be comfortable with being uncomfortable, because that's medicine.
All right. So thank you so much for joining and speaking to all of us. I know there were a lot of questions that were asked today. So thank you everyone for asking all these questions. It was a lovely session. We learned a lot, and I especially learned a lot about family medicine that I didn't know before. So yeah, thanks so much for joining us today. For everyone else, I am posting the link to the Google form right now, and it should be in the chat right now. So just make sure you fill that out by 9 o'clock p.m. EST, and then so that you can get your shadowing hour. So thanks again for joining us. Bye.
Thanks for having me.